Yes, yes.
Right. Then we start already. Then we ask how of an anus. Mouth anus. Then one of the Mustafa, can you tell how do you think that presented? One.
Hello.
No, sir, there's some sort of a tapping sound, sir.
It's very difficult to hear what you're saying.
Sorry, can't hear. Okay. Subhani, can you hear now?
Yes, sir.
Yeah. Can you tell now how this patient would have presented?
He would present with severe anal pain while on defecation and sometimes with some streak of blood while defecation as well, sir.
Yeah. Okay. Now this is a picture that was seen while inspection. You trying to do a PR, right? So can you
Yes, sir.
describe what you see? Can you?
Yeah.
Hello. Can you hear? Can you hear?
Yeah,
Tapping sound is so annoying. Hello? Can't hear.
Tapping sound එක එන්නේ සර් ගේ අර මේකෙන් එන්නේ. සුමුත් සර් එනවද?
yes, I can hear. මම මේ mute කරගෙන ඉන්න බලන්නේ මේ.
Yeah, can't maintain the discussion. කරන්න හරි ගත්ත කතා කරන්න බෑ. මට ආන්සර් කරන්න කතා කරන්න බෑ.
Right. Can you hear me now?
Yeah, can hear. Yes.
Can hear, sir.
Yeah.
So what we see here, others also can hear, I suppose, neither.
Yeah, I just
So what we see here is a breach in the anoderm, right? At 12 o'clock position, 6 o'clock position. I don't know, sort of, I can't orient exactly, but looks like 6 or 12 o'clock position. So it is a very superficial ulcer. This type of sorry. Yes, it is a breach of anoderm, and it is very superficial. So it is it is pathologically also it is a ischemic ulcer because the brunt of the ischemia is felt to the mucosa. And so as this is very superficial, this is very painful. And there is no evidence of healing here. The base is little sloughy, but it is not infected. So this is typical of an acute.
So in sense now,
Sorry? Pardon? What's happening?
said that
I can't hear you.
right? So when you say acute here, what's a term?
What's happening? Can you hear me?
Can hear, sir. I think Rohan sir is not there.
Is it something to do with the internet connection?
तुमचं अनम्यूट कराना हरी मेरे को
Sir, Rohan sir mute වෙලා වගේ.
මේ සර්ගේ මේ ෆෝන් එකේ සද්දෙත් ටිකක් අමාරුයි වගේ සර්. මේ මේකේ සද්දෙත් එක්ක මේ කම්පියුටර් එකේ මේ ඩිස්ටර්බ් වෙනවා අර ටක් සද්දෙත් එක්ක. අරුණ
ඔව් මේ මම ටැබ් එකෙන් කරන්න අමාරු ඉවටයින් මට විනාඩියක් දෙන්නවා.
No, I can't discuss with these other guys. If our people are not answering no registers, it take hours to answer.
ඒක තමයි. Okay.
Smooth නැතුව
සුමුස නැතුව ඒක නෙමෙයි. මොකද කරන්නේ?
Bye. I think we'll Adabi Pundak. Okay, do you all have any questions to ask? I think probably we'll have to probably do it tomorrow.
I think so.
Yeah. Do you all have any questions to ask? I'm sorry about today, almost 250. I'm sorry.
I got some short cases, but if you want, you can discuss. Otherwise, but Sumusa is not there, ne? So
Sumutsa will join, ne, Ravna? Sumutsa might join.
Yeah.
I will join from another phone.
Yeah, okay. මේකත් එක මේක සද්දෙත් එක බය කරන්න සද්ද එනවා. Yeah, Sujinta.
Yes,
yeah,
sir.
okay. So I'll put up this. Can Either you ask questions from me, I'll ask questions from you.
I'll ask questions.
Okay, right.
Easy.
Yeah.
Hello.
Hello.
Yeah.
Where's the short case or whatever? Rohan, you're putting something.
Yes, sir, reporting.
Now it's good.
Sir,
now it's okay.
Yeah, it's okay. Yeah.
Yeah, it's okay now.
Yeah.
Okay.
Just a minute. ප්‍රමුත් දැන් යාවනේ. ඔව්. මේ කට්ටිය නතු වීඩියෝ කරගන්න දෙයක්. Yeah, can you see the picture?
Not yet.
Okay.
මොකද්ද?
I need to put the Maidan. Can you see the picture now? Not yet.
Now we can see.
Yeah.
Yes.
Okay. Right. So okay, this page can see now, no?
Yeah.
No. Okay. So, okay. This patient came with sudden onset, complaining of severe perianal pain. Came up for about 2 days duration, and there was a bit of blood when he passed stools, and then he was not sure whether it is before or after, but what he felt was the bleeding was fresh blood that came after defecation. That is the this is what was seen after the on inspection. Sir was telling, okay, this is like an ulcer. 11 o'clock we can't expect it, but looks like 12 o'clock. Why did you say why did you suspect 12 or 6 o'clock? Was there a reason for that?
If I take 6 o'clock,
Yeah.
now the 12 o'clock position, you have sort of a more the exact opposite position, you get sort of more converging convergence seen on the inner mucosa. That's the most thickest part of the sphincter. So that's why I thought this is 6 o'clock and this is 12 o'clock.
Okay, when you see something like this, what will you do now? How will you proceed?
Now, with the history, he said sort of this acute onset, very painful with defecation, and pain lasts some time after defecation also, associate with bleeding, not profuse, small amount. With this history, it is all suggestive of an anal fissure. And the other component of the history in favor of an anal fissure is a recurrent episode.
Yeah.
This could be the first episode as well. So anal fissure is a clinical diagnosis. You don't need, with this history, if you see this, you don't need any other investigations to make a diagnosis. So history and examination is good enough to make a diagnosis here.
Okay.
But in case, if you see more of these And if you see fissures in some other positions like 6 o'clock, 3 o'clock, 5 o'clock, 11 o'clock, 2 o'clock, and multiple fissures, and some of the fissures in different of heat, then you may a rare possibility of Crohn's disease as well.
So what you are saying is to diagnose fissure, just by inspection, can you is it enough? Is it enough to diagnose a fissure, or do you need anything else? So if you see something like
history and examination. History and examination
you
is
will
enough.
not the PR examination.
PR is very painful here. You can attempt to do a PR, but you don't have to do a PR because it is very painful.
Okay. Right. Pramod, you are there, no?
Yeah.
Pramod, now let's say you have now the fissure, and then when you try to do PR examination, it becomes extremely painful.
Yeah.
How common are these fissures? Like you regularly see fissures, or is it a common?
One of the commonest presentations to outpatients department, even some of the PR bleeds, patients who come with rectal bleeding, complaining rectal bleeding, if it's painful bleeding, it's most of the time it's a fissure. It's one of the commonest, I would say, presentations in the outpatients.
Okay. Is there an age, common age? Is it common in young people, or is it common in elderly? What do you think? What do you see?
It's usually in the middle ages, like in the sense 30 to 50, I would say. People, because this is we need to talk about the pathophysiology of this fissure. So why now? Sumit sir was telling about 12 and 6 o'clock. So why do people get fissures at the 12 and 6 o'clock position? It is mainly due to the blood supply of the anal sphincter complex. How the arteries come through the anal sphincter complex at 3 and 9 o'clock positions. And then there is a sort of a watershed area in the 12 and 6 o'clock positions. So I think the initiation of the fissure happens with maybe a passing of a hard stool where there is a small ulceration in the anal mucosa. And then because of the pain, the anal sphincter complex goes into a spasm, which obstructs the blood supply, mainly to the 12 and the 6 o'clock position. These are the sort of like the watershed areas where you commonly get these, there is a relative ischemia compared to other areas. That's why we say when you have fissures in 9 or 3 o'clock position, it's more likely you're looking at some other cause like a Crohn's disease with multiple fissures in other areas. Okay. So it is mainly of the area. So in people with young, strong sphincters, it's more prevalent than in the older people with a less stronger sphincter complex, the muscle mass of the sphincter.
Can like in
I just have to add few things. You asked sort of now this can occur in young patients as well, small children as well, and usually it is preceded with the incident of passing hard stools. But if you ask patients, 50% of them deny of constipation or hard stools. That may be one-off event. Right? So it is not a constant thing, or sort of about 50%, only 50% will have or give a history of passing hard stools. And as Pramod said, sort of it is a vascular ulcer. So management also like management of a vascular ulcer.
Yeah, another thing I have noticed is now it is actually common in younger compared to maybe older people. I have just wondered whether it's relationship with the sphincter tone, because the sphincter tone is a
muscle mass in the sphincter.
Yeah, Is there anything like that? Can you relate?
Yes. Two things. Young patients, they involve in a lot of other activities. So they don't drink enough water. So probably more outdoor activities. So they may have sort of higher incidence of passing hard stools, and they strain hard. And relatively now, when you take females, after a while, sort of their sphincter is usually lax, anal sphincter after first baby, even it is cesarean section. So younger patients, of course, they have more rigid, the tone in the sphincter is higher than older patients. So both may contribute, the sphincter tone as well as passing hard stools.
So Pramod, if like this comes to you, let's say a patient comes to you as on the in your outpatient clinic. So how will you start proceeding?
So it's about the history mainly. I would always take, because these patients complain of pain, or most of the time pain with a bit of bleeding, sort of like passing streaks on the stools, they would have noticed. So I would take a complete history to exclude other like a long-standing problem like a tumor, the patient be severe pain, and I would also look for this word excruciating pain. In Sinhalese, I would sometimes ask, is it like last through it? Patients will characteristic say, when I defecate, there is this severe pain, like I'm passing a piece of glass through my anus, and then the pain persists also after you defecate. The pain persists for a while, and then they also feel this tightness of the anus sphincter even after you pass the stools. So those are characteristic signs, and they may have passed a bit of blood, one drop or two, or streaks of blood on stools. Some sort of a bleeding will be associated if they have observed it. And I would take a complete history as for any rectal bleed or altered bowel habits to exclude the possibility of a colorectal cancer. Examination part, as Sumundu sir said, it's not complete here. What we usually do is put the patient in the left lateral position and widen the buttocks, the two buttocks to examine the anal canal, rather than putting in the finger. Once you apart the buttocks, you can clearly see the fissure either at the 12 o'clock or 6 o'clock position, and you can also say whether it's a fissure acute. Sometimes looking at it, the chronic ones will have sort of plastic edge and some even sloughed off, whereas the acute one is more red and angry. So more than that, I would not attempt to do a rectal examination if it's very painful, especially in acute fissure. I would leave it for later once I've started the treatment. If you can perform a rectal examination, characteristically when you press on the site, the 12 or the 6 o'clock position, the patient will just shout in pain, will be howling in pain. Most of the time, we don't get to do anything else other than parting the buttocks and looking at the anal mucosa.
Pramod, what is common use?
Yeah, a sentinel tag is a skin tag that you see in relation to a chronic fissure.
Somewhere you see somewhere at the apex,
at
right?
the apex, yes. That indicates that patient has been having this long, maybe fissures have healed and reappeared and so on. So you get it at the edge, and it's just a skin tag at the very edge of the fissure.
So you get sentinel mainly in the chronic fissures, not in the.
Yes, once even sometimes after the fissure is healed, you can see the skin tag being left out, and patients are more worried about the skin tag rather than the fissures. So it's mainly related to the chronic fissure, not the acute one.
Okay, right. Yeah. Yeah. Okay. Sumut sir, so what is the like you best way of relieving pain?
Now their pain is due to it get worse because of the spasm of the anal sphincter, and you get sort of severe pain when they are passing, when they pass to passing stools also. So the simple analgesics usually doesn't work here. So you may need sort of, if you are giving local anesthetic agents like lignocaine gel, 2% lignocaine gel, may be helpful, especially when pass stools and sort of after passing stools. But the next time when he goes to pass stools, also he gets this pain. So most of these patients we can manage conservatively. Majority can be managed conservatively because this will heal even if you don't do anything. So what you just have to do is relax the sphincter and let it heal. But the problem is 85% of them will recur. So initially what you should do is having good anal hygiene and relieve edema. For that you can do or advise them to have sitz baths twice daily, or if he has enough 3 times a day is also okay.
Anyway,
Then,
tell exactly what do you mean by sitz bath. Let's say you are advising someone to take a sitz bath. What exactly will you tell?
okay. What they should do is they should sort of sit on, they get a large basin where they can sit in without much of a discomfort. If he's a, so you need a sort of a big one, but it is not very deep also. So you pour lukewarm water where you can dip your hand without much of a discomfort, right? Not a sort of burning hot water, and add handful of salt, table salt, and sit it. If you don't any pain, you may add more salt. If you have sort of significant pain and you can't sit in it, you can add more water, right? So with trial and error, you can dilute or more concentrate for you to have sort of more comfortable sit in this salt water.
How long?
You sit in there for about 10 to 15 minutes, right? So usually it is advised to do that after having a bowel motion. That will sort of improve their perianal hygiene as well and reduce edema, right? And soothe that area, so post defecation pain will be relieved. Before defecation, we advise them to apply lignocaine gel for them to have more comfortable defecation. That will relax the sphincter also, and it acts as a local anesthetic.
Yeah. So where exactly should they apply the local anesthetic cream? Is it over the fissure or is it all around?
It is you apply it right around the anal verge, right? And nowadays we tend to apply nitric oxide donors. They are sometimes nitrophis, that is GT and glyceryl trinitrate 1% or 0.5%, or you can, pardon?
If I have a diagram, if I can share the screen while you talk.
I'll share my screen just a minute.
Yeah.
Yeah. Okay.
Okay.
As Pramod said, sort of this is due to positive blood supply mainly at the 12 and 6 o'clock position. Why do they get positive blood supply? Because the blood supply to the anal mucosa travels through the internal sphincter and perpendicular to the internal sphincter. Internal sphincter is continuously, it has a tone all the time, right? When there is a higher tone, it squeezes the blood vessels and the blood supply to the mucosa is reduced. There are two main vessels coming from 3 and 9 o'clock position. So the brunt of the ischemia is felt at 12 and 6 o'clock position. That is why you usually get fissures at 6 o'clock and 12 o'clock position. So if you relax the sphincter, the blood supply improves. So relaxing this sphincter can be achieved by nitric oxide donors. Like sort of when you get ischemic heart disease, you use GTN, glyceryl trinitrate. So a similar drug we can use here also, GTN cream. Only side effect, it is a very potent drug, it is very effective, but it doesn't last long and it causes sort of troublesome headache in a considerable number of patients. The longer acting drug is calcium channel blockers, diltiazem, right? So we can use diltiazem, not that potent, but it lasts long, less headache. Right? So other chemical sphincter, this is called chemical sphincterotomy. We don't cut the sphincter, but we relax the sphincter. The other modality of relaxing these are the common ways of relaxing sphincter. So basically what we try is initially sitz baths, NSAIDs, lignocaine gel, and nitric oxide donors in the form of glyceryl trinitrate or calcium channel blockers in the form of diltiazem. If things doesn't work and if we need more prolonged sphincter relaxation, we can use Botoxin. It is a reserved drug, not used in every patient, and mainly because it is very expensive. And you inject it in the intersphincteric space. The results, the effect may last for about 2-3 months. But it is also temporary. And next modality of management is
now I've seen sometimes patients presenting with, most of the people we prescribe laxatives as well.
People
laxative like recommend for
lactulose,
fibrogel.
Lactulose.
No, fibrogel.
Fibrogel is really not a laxative. It is it increases the bulk of stools.
What about
And
a drug like that? Is it recommended to give it or?
yes, the thing is sort of it increases the bulk formers. Absorb lot of water. It has a lot of fiber, so it absorb more water. So stool is bulky but softer. So when bulky soft stool comes to the lower anal lower rectum, dilatation of the anal occurs. Right? So if the pain is relieved with lignocaine, this reflex dilatation of the anal facilitate this stool spine without much of a pain. Problem of these patients is their stools are hard and not formed. They are like pebbles. So that is why they have to strain, because they don't expand, dilate the lower rectum adequately to relax the lower ending. So they have to strain on stools a lot with a relatively tight sphincter. Bulbs are definitely helpful, and though they are bulky, it is softer, it dilates and it relaxes, so it facilitates.
Yeah. What about other laxatives?
One thing I forgot to do is 95% of these patients have tight sphincter, but a minority, 5% of them, the sphincter tone is not increased. It may be normal or less than normal. This is a subgroup of patients. The management of this subgroup is a minority. It is different. The patient having higher tone.
What about lactulose? Do you usually
I don't recommend lactulose. I know sort of people recommend lactulose. The problem of lactulose is it increases the number of bowel motions. it doesn't increase the bulk. So it may cause more pain because it increases the number of bowel motions. But things like liquid paraffin,
Paraffin is better.
yeah, that may be helpful because it with bulk formers, because it creates a lubricant layer around feces that will facilitate easy passage of stools through the lower anal canal.
I think
Shall we ask
vast
a question from
majority of doctors in the outpatient department, even at Ragama, they prescribe lactulose as practice for these patients. They come and that symptoms first because they are now going to the toilet about 3 times a day with a painful fissure, and it's not going to help them. So, the good lesson from medical students, lactulose is not preferred in this instance.
And other malpractice is giving antibiotics,
Yes.
especially amoxicillin and metronidazole. Right? I have seen these two have been misused. Though this is an ulcer in the anal canal, very rarely these get infected. Only about 2% fissures get infected. So majority of the fissures don't get infected. Prophylactic antibiotics are not going to work in case it is infected ears, and usually it infects because due to application of unusual
Like
things.
steroids.
Yes. So lactulose, antibiotics, steroids are not really indicated in the management of fish.
Shall we ask a question from one of the medical students? Now, what do you think about giving maybe something like clean prep? If you get a MCQ saying clean prep is given, we'll name someone. Asiri Karuna. Yes. Unmute Karada.
Yes, sir.
Yeah, what do you think? If you get an MCQ saying clean prep can be given in acute fissure as a laxative. True, false?
False.
Why do you think it's false?
It increase the frequency, but not.
Pramod, what do you, how can you help him?
What did he say? I didn't get the answer. And what was the reason he gave?
He said it increases the frequency. I just asked why, how it increases frequency.
Hello.
Yeah.
Hello. So yeah, do you know what's in clean prep? Do you know what the substance which is prep?
Sorry, sir, I can't remember.
Yeah, can't remember. That's
so.
Polyethylene glycol.
Yeah, it is polyethylene glycol, right?
Yes. Yeah. How does it act, Pramod? Hello. Sumusa, line again, no?
Yes, can you hear me?
So how
all right. Polyethylene glycol doesn't get absorbed from the gut. So when you have it higher volume, it is accumulated in the small bowel. It distends small bowel, so create more propulsive mechanical of the bowel. So it doesn't form any stools. So it increases motion, and more you drink, more it is passed without being absorbed. So if you have 3 liters of clean prep, you pass minimum of 3 liters of fluid through the anus. So it increases in bowel motions. So every time when he passes, he gets more pain.
Yeah. So in principle, what the laxative that we are going to use should have the property where the stools are softer, but the frequency should not be increased like in some of the laxative that we use.
Yeah.
So you said
so bulk form,
yeah,
they are called the bulk formers stools.
Yeah. So you said that sometimes you use Botox injection. So when do you use that?
Hello. Hear me?
Yeah, promote can. I know that. Yeah.
I know.
Yeah. Yes. Yeah. Yeah.
Are we?
Now we are. Yeah. That's fine. Pramod. Yes. Now, so Mutsa said earlier, Pramod, he's using sometimes Botox injections. When do you use that? In acute fissures.
So, for that, can I ask now? He said he's using nitrites, calcium channel blockers, so many options. Do you use all of these at the same time, or is there sort of a stepwise treatment that you take up?
Yeah. Now, initially we used sitz baths, local anesthetics, bulk formers, and a lot of fiber containing diet. If it doesn't settle with that, only we start chemical sphincterotomy in the form of GTN or diltiazem. Mainly because it has some side effects and it is not a permanent thing. And most of these fissures will settle within a week.
Is there an order in which you use first calcium channel blocker, then nitrate, or?
Yes. I use sort of diltiazem first because it has less headache, less potent as well, but it lasts longer.
And then nitrates, and if that also not does the job, then you go for the sphincterotomy. So,
yes.
Yeah. So when you're selecting sphincterotomy, now there is chemical, the Botox one, or you can do a surgical one. So if a young female patient comes in, would you prefer to do a Botox or do a surgical sphincterotomy?
Surgical sphincterotomy is always a permanent procedure, and it associates with some form of incontinence. This incontinence, they have found 15% of patients do have some form of incontinence, but that may not be clinically significant. Patient may not, if you use sort of incontinence course, they may not reveal or they may not come and complain of it. But if these patients are followed up for a longer time, and usually this is a problem of young age, but when they come after they deliver 2-3 babies, and when they are older, they found sort of incontinence incidents in whom had any form of sphincter surgery in the form of sphincterotomy or anal dilatation is significantly high. So sphincterotomy or surgical sphincterotomy should be done when there is no other option. And even the patient is young, you may not sort of get away, you may get away with the problem at that time, but it doesn't very likely he or she may have incontinence, especially females, may be having incontinence in their older age. And if you do anal manometry, 15% of them will have poor sphincter tone than normal values after sphincterotomy, even with internal anal sphincterotomy, controlled sphincterotomy, and it is much higher in patients who undergo anal dilatation.
And clinically, they may present only with sort of incontinence to flatus or small accidents when they have loose stools. It's never a gross, if you do it properly, it's never a gross incontinence. Personally, I always try to reserve surgical sphincterotomy as the last resort, especially females. I am very reluctant to do it. I always try with Botox. Usually, when you give it for the 3-month period when the sphincter tone is lax, you can cause about 60-70% will heal the fissure, but it may recur. The problem might recur because we haven't addressed the anatomical issue there. But even after you inject Botox, do you still advise the patient that they might experience a bit of incontinence?
Yes, definitely. Most of them will have some form of incontinence, but it is not permanent. And the issue is now, this is a recurrent problem. 85% of the patients with fissures, if you don't undergo surgical sphincterotomy, will get these symptoms again and again. But when they are getting older, after 40, 50s, so frequency of symptoms will be less, right? That is usually due to laxity of the sphincter with aging process. And if you do a sphincterotomy, that may be further lax. Only of chemical sphincterotomy in the Botox is the Botox is very expensive.
Yeah,
and if you have to give, pardon?
Yeah, yes.
Hello?
Yeah, hello.
Yeah. You have to give about 100 units, which will cost somewhere around, I think, 25,000 rupees.
35,000.
Yeah, and that usually lasts for about 3-4 months. So annual cost would be 100,000.
Yes. Especially in females who haven't yet had a childbirth, I'm usually very much reluctant to go for surgical sphincterotomy. But in males, I have a lower threshold, especially if it's recurrent. We'll go for a lateral sphincterotomy to save the cost, especially in our setting. Yeah.
Yeah, can you briefly tell what done you in this sphincterotomy? What do you mean? What part do you remove? How much you remove? In surgical sphincterotomy, what exactly is done?
So what we usually do is we release the internal anal sphincter and not the whole thing. It's just a part, about 1 centimeter depth of the internal anal sphincter at 3 o'clock position. Right? So this has to be done by you need to have a proper understanding about the anatomy of the anal sphincter complex. And there are 2 ways of doing this. One blind technique where some old senior surgeons used to do, by inserting the knife in the intersphincteric space and just putting the sharp edge towards the internal anal sphincter and cutting 1 centimeter. But usually we do it, I prefer to do it under direct vision. Make an incision at the intersphincteric groove and put a sort of a artery faucet for a mosquito into the intersphincteric groove, and then get 1 centimeter of internal anal sphincter, which looks like a whitish band. It's very characteristic. You can see this, and then divide about 1 centimeter depth of the internal anal sphincter. And also, after doing this, you can feel the gap like a V in the internal anal sphincter if you palpate through the anal mucosa. So, do you do differently?
No, I do the same. And few things, when you look at the history, the anal fissure walls loads the anal dilatation.
Yeah, when we have a register, we usually a lot of MDA.
Yes.
Manual dilatation of the anus.
Where you are supposed to put 4 fingers of each hand, so 8 fingers, right, all together, and use your whole energy and part the anal canal. This also rupture the internal anal sphincter, but this is not a controlled rupture. It ruptures in several places, and the length also cannot be assessed. So most of these patients, if they are young, they don't get sort of clinically significant incontinence. Symptoms will be relieved quickly, but the incidence of incontinence at a later age is very high. So they then decided to do more controlled sphincterotomy. The first form of controlled sphincterotomy, people thought we'll cut the fissure, sphincter at the place of the fissure, called fissurectomy. So without creating another wound. Now the process promote the describe, make an intersphincter groove, right? Then you hook the internal sphincter and divide it, rather than why can't we divide the sphincter which is exposed? You don't have to make any incision. You just hook it up and sort of divide. Any registrars, any ideas sort of, and in fact, this was done initially, right? And given up. And I would say it is given up, don't do it. But why it was given up, and theoretically it sounds easier, right? If the fissure is at 6 o'clock, you just divide the sphincter. If you, what's the point of dividing the sphincter at 3 o'clock? Right? Supun?
Hello, sir. Can you hear me?
Yeah, can. Yes.
So, as you said that the inner canal, the blood supply is weakest at 6 o'clock and 12 o'clock position. So, if you are doing the sphincterotomy at 6 o'clock, where the deficit is, you are adding more injury to already injured area. So it won't heal as much as it won't heal, sir. So to avoid that, we don't do that at 6 o'clock. Instead, we do it at 3 o'clock. And the whole point is to release the inner sphincter tone so that the blood supply will increase to that area, reduce spasm. So that will actually heal rather. Hello? Hello, sir. Can you hear me?
Yeah. Okay. What you're saying is clear. Yes.
Yes, partially correct. But idea is to divide the sphincter, right? The blood supply is to the mucosa. So blood vessels travels through the sphincter. So wherever it is divided, it's like a rubber band, internal sphincter, right? If you divide the rubber band at any point, the tension all around the rubber band is lost.
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir.
What we want is the mucosal healing, not the healing of the divided sphincter.
Yes, sir.
Right? The reason why we don't do that, people have done it. So what they...
Sir, shall we ask from medical students whether they can think of a reason why it is not healing? When if you divide from this fissure, can someone think of a reason why it should not heal, will not heal? Probably you can answer if you think about it. No, I mean, it's not only medicine. Anyone? Yeah.
So we leave it for the homework.
Huh? Can someone guess at least? If you guess, we'll tell what the reason is. Yeah. Yes. Sudhita, kya kiyanna balan? Yes.
Sir, because at the fissure area, it is exposed to the fecal matter, and then the same area is exposed, the healing would be less.
Okay, good try. Come on, sir.
Right. Now the fissure, there is only a mucosal breach, the superficial ulcer. There is nothing wrong in the muscle. Muscle has a very good blood supply. But when you compare with the external sphincter, one way of identifying this muscle is this is little wide. Right? The registrars, you should this is one way of recognizing the internal anal sphincter. The external sphincter muscles, if you take, because when you are dividing, you have to divide little bit of corrugator cutis ani muscles. They are red, but after that you see sort of red muscles on the lateral aspect and white muscles on the left side, and when you hook it up on, also you see it is white piece of muscle behind that. So in the fissure, only the mucosa is breached and it is supported by underlying internal anal sphincter muscle. If you divide that there, what will happen is internal anal sphincter also give a part that area. So when it heals the fissure mucosa, it heals forming a gutter, right, like a keyhole. So that gutter leads to continuous mucus discharge or incontinence, right? So the patients who undergo fissurectomy will have continuous mucus incontinence, right? The place where we make an incision to do an internal anal sphincterotomy, a lateral anal sphincterotomy, it's not the anal mucosa. That's very important, right? We make an incision at the intersphincteric groove. It is outside the anal mucosa, right? So it doesn't form, when it heals, it doesn't form a gutter inside the anal canal. I think you understood.
Yeah, actually, when I was
sorry, I can't hear you. I couldn't hear, Rohan. Sorry, I couldn't hear you.
So,
hello. Hello. Hello.
hello.
Yes, sir. No.
Hello.
Couldn't hear a word. Anyone else? Can anyone else hear me?
Yeah, we can hear.
Suchinta, Rohan, I couldn't sort of hear you.
Can't hear. Can't hear.
Could you hear Rohan?
Can't hear.
No, we can't. We can't. We can hear you well, but we can't hear Hans's voice.
Okay, until he gets his connection. So that is why we don't do fissurectomy. That is called fissurectomy, which was done for few years, I suppose. When I was a registrar, it was a procedure and given up because of this keyhole deformity, which leads to mucus incontinence. Right.
I have got a couple of questions to ask.
Because it is a vascular ulcer, you have more rights to ask questions.
What is the upper end of your lateral anal sphincter, Ramila? What's the upper end?
That's what I was trying to sort of tell you now. You shouldn't go beyond the dentate line. The incidence of incontinence is high, and sort of you will not achieve anything more because this is a superficial ulcer. Below the dentate line, you are not going to achieve any pain relief if you do it above the dentate line. But still, you don't have to even do right up to the dentate line. Current guidelines are you can do at the you don't have to go beyond the height of the fissure. This is very difficult to assess, but sort of it's when you are doing it in prone position, especially, it is not that difficult. You can assess it and divide it. And other important thing is you should divide only the internal sphincter and not even a fiber of external sphincter. So it is important to get into the sphincteric group. It is avascular and divide it. And you shouldn't divide the anal mucosa. If you divide the anal mucosa now in the open procedure, you divide the anal mucosa also. So you will get the same complication as fissurectomy. You divide the anal mucosa, even if you accidentally damage the anal mucosa. So one should not go from the go between the mucosa and the sphincter. Shouldn't go, right? You should go in between the internal and internal and external sphincter and hook up the sphincter. So those three things should be kept in your mind. Anything to be added or
I got another question. Sorry.
Used to say was when you
Sorry.
cut,
I got another
feel
question.
the gap, it should be like a, not edge or a parallel, not two parallel lines, but because you have not cut the whole.
Because part of the internal anal sphincter is left behind.
So you should feel a V, not a two parallel lines. The gap.
And once you do a sphincterotomy, you shouldn't sort of put your finger or the hand inside and sort of complete the sphincter by parting the anal canal. Rohan is not yet connected, neither.
I'm
connected.
All right, Rohan, but you want to ask?
No, it's not a question. What I was saying is when I was registered, I actually thought it's done that you have to divide the sphincter on the fissure. So it took additionally it took long time to heal, because when you divide the edges of the sphincter, I think it opens up the fissure, and it takes long time to heal also. The patient keeps on coming to say that they are not healed yet. Yes. Yeah. I had a question, no?
Did you take position also?
Yes.
Why not? Why not 9?
You stand from the patient's right hand side, right? So that is why customary you do it at 3 o'clock position. You can do it at 9 o'clock.
When the patient is on prone position, usually I prefer to do it.
Yes.
I'm lefty, so I do.
And so what about in a chronic fissure, doing an internal anal sphincterotomy at 3 o'clock and then closing the edges of the fissure, will it make it faster to heal? Scoop up, scoop and suture the edges of the chronic fissure.
Same problem in the chronic fissure. Yes, that guttering effect will be there.
No. Doing the sphincterotomy at the 3 o'clock position, and just to make it faster, the healing process, come back and suture the edges of the chronic fissure.
Yeah. Now, I of course, if there is a really chronic fissure with everted fibrotic edges, right? What I do is sort of trim them and advance rather than taking mucosa and suturing. I don't have any experience in primary suturing the edges of the chronic fissure after dividing the fibrotic edges, but I do mucosal advancement flap closure.
One other question. Now, when you give Botox injection, you still give the Botox to the 3 o'clock position, or you do circumferentially? Botox.
Yeah.
To 9 o'clock and 3 o'clock.
Same positions. To give it to the internal sphincter. Internal anal.
Okay. So, do you have to always remove the sentinel tag, or do you leave it according to the patient's preference if they are like worried about it, or is there any?
If you remove the sentinel tag, that will add more pain. The idea of this procedure is to relieve pain. Right? Moment you do the sphincterotomy, the patient will be relieved of pain. But if you do excision of the sentinel tag, they will continue to have pain. But there are reservations. Some patients whose sentinel tags are very big, and they are so big that they can cause some obstructive defecation also, and very cumbersome. In that case, you remove the sentinel tag after telling patient that your post-op pain relief may not be expected as for a patient who undergo only a sphincterotomy. Otherwise, we don't remove the sentinel tag.
Thank you.
So, is there a place for biopsy in atypical anal fissure?
Routine fissure, if it is ischemic ulcer, we don't take any biopsy. But if you are suspecting of Crohn's disease, what you should do is you are not supposed to do a sphincterotomy. right? What you should do a colonoscopy with ideal intubation and an endoscopy, and take do a biopsy series. And if you have some unusual fissures, of course, if they don't have any evidence of inflammatory bowel disease in the rest of the bowel, of course, you can take a biopsy from the anal fissure.
Thank you.
But Crohn's disease patient, the primary site of biopsy is not the fissure.
So if it's a Crohn's fissure, when do you time, like what's the timing of the colonoscopy?
There is nothing like that.
I usually do it
They
when the
present
pain is
with
not there.
now.
Okay.
Their problem is not sort of very tight anal, right? So in the acute stage, you can do colonoscopy. Only problem is sometimes they have multiple fistulas and sort of infected fissures as well, especially the patients who are on steroids. Those patients, if there is evidence of sepsis, we postpone colonoscopy, but otherwise you can do colonoscopy
Okay.
earlier.
And also, for the students, you should never forget the endoscopy part. Once you treat the fissure and the pain is gone, you have to evaluate the rest of the bowel, especially if you suspect something like Crohn's. Some guidelines don't always recommend doing a lower GI evaluation, especially in young patients and having a clear-cut acute fissure. They do not recommend doing endoscopies and just go ahead with treatment. But if you are doing evaluation, you have to wait till the pain is gone. And also in children, especially multiple fissures or fissures in irregular that have positions like 5 o'clock, 7 o'clock, or even 3 and 9. You should also exclude abuse, non-accidental injuries, because it's not a regular place to get fissures, as we explained, only except for 12 and 6.
Yeah. So far we how fissures present, symptoms and relationship with the stools, and if someone presents when you examine inspection, what you see, and probably that you will not be able to complete your PR examination. And then we discussed about the principles of management, pain relief, mainly NSAIDs, and then we discussed about different types of laxatives and the importance of the bulk stool softeners or bulk forming laxatives. And we discussed about the importance of relieving edema, and we discussed how to give a sitz bath. And then we discussed about sphincter, different techniques of sphincter relation, sphincterization, maybe local applications, and sometimes maybe injections. And in cases we thought extreme cases we think of even surgery. And then once the acute stage is settled, we about the importance of looking at the event in the colon, maybe a colonoscopy depending. So that's what we discussed up to now, no? And then we surgery, but done in
technique of sphincterotomy.
Yeah. When you call it a chronic fissure, is it important to define acute fissure? People are splitting hairs on like, is it important to differentiate like that acute fissure from a chronic fissure for the management point of view?
Textbooks describe chronic fissure are the fissures which has been there for more than 3 months. And their appearance is also different. Right? They have sort of fibrotic edges, and they are not so painful. Probably the patient is quite used to pain. Right? And they are, when time goes, even the fissure heals. Because of the fibrotic edges, they get sort of little bit of incontinence for the liquid feces. So after 3 months only, sort of we called it usually technically chronic fissure.
But the management
treatment is also same, but if they have the incontinence and the keyhole deformity, that will not relieve just by doing a sphincterotomy. So they may need mucosal advancement, flap closure of the fissure.
Sir, I have a question, sir. Is there a recognized practice that DTSM is mixed in lignocaine and applying it into the
I didn't follow your question.
Asking whether you can mix the tablet, DTSM tablet in ligno. Is that what you're asking?
Yes, sir.
No, that's not it's not the accepted practice. DTSM is
Pharmacokinetics is sort of now preparation of this drug is staying in a stable form. Now nitric oxide donors are very unstable. You know, in 1999, that was the molecule which won the Nobel Prize. Right? So it has been there since for many years, but sort of people couldn't recognize this such unstable molecule. It's important. So when you are preparing, you should just think that drug is not going to work. You have to have it in a stable form for some time for it to act. So I think crushing a tablet and with lignocaine gel and applying it is not going to work. These drugs are stabilizing special pH parameters, special temperatures as well. That is why your nitrophils and things are kept in a refrigerator because it's so unstable. You take it and apply it. So things like that. Pharmacokinetics also important.
both the nitrates and calcium channel blockers. You can't crush the tablet and do. People have tried doing it, but it didn't work.
Yeah. Are there any other questions from students? Okay, no questions. Pramod, I sent you a video through email. Pramod?
Yeah.
Are there any questions from students? No? Right.
Excuse me, sir. I have a small
About,
problem. Sir, do we say like more commonly fissures are? Now, Sumudra sir said that mostly common with passage of hard stools, but not this is not seen in 50% of the patients. But is there also can we also see fissures in those with diarrhea, and how is that occurring due to the increased frequency?
What I said was only about 50% of the patients will have a history of passing hard stool. So others may not have passed, or they don't have a history of passing hard stools. So we can't correlate this solely to sort of passing hard stools. As I said earlier, this is a ischemic ulcer. Primary culprit is mucosal ischemia. So mucosal damage can occur due to hard stools. They can occur due to many other reasons as well. It is like a ischemic ulcer in the foot. Right? That trauma may be very trivial. So it may be sort of sometimes your nail can sort of accidentally damage the anal mucosa when you are washing. So when you are wiping, some rough toilet paper can breach the mucosa. So passing hard stool is not a constant feature.
Okay,
the underlying culprit is ischemia.
Okay, sir. Thank you, sir. And sir, can hemorrhoids and fissures coexist?
Yes, hemorrhoids are very common, right? So there is no relationship between hemorrhoids and fissures, but they can coexist.
Okay. Thank you.
Now, your question, don't type and send it to me. I'm not conveying your questions. So if you have to ask questions directly. No one is going to laugh at you. We are not going to, you ask a question. You are going to ask questions back from me if you ask a question. So that is guaranteed. We will not ask questions back from you.
Excuse me, sir.
Yeah. Yes.
Sir, what are the advices we have to give to the patient after the lateral sphincterotomy surgery, sir? Is it sits bath advised after surgery?
Advice mainly again the same thing. There is a wound around canal. You can't dress this wound. It is not possible to dress this wound. You can't apply any dressings over it. So you have to leave it. So most of the perineal procedures, sclerotomy, hemorrhoidectomy, fistula surgery, you can't dress these wounds daily as you dress wounds in other part of the body. So what is important is good perineal hygiene and reduce edema around it. So for that, what we should do is we advise them to have a good shower after bowel motions and have a sitz bath, the salt water bath. Applying anti creams are not recommended unless there is a reason. But there are certain other medications which relax the sphincter tone and venous congestion. The venotone, they are like the tannin containing drugs, micronized flavonoids. So that reduce the venous congestion and edema around it. They have some effects, but they are also not essential. Mild analgesics are quite enough, paracetamol and NSAID after this thing, and the bulk formers, because that will dilate the sphincter and easy passage of this thing, and little bit of cremafine if it is really painful. That is more than enough after sphincterotomy.
Thank you.
Got the video?
Yeah, there is a video of a polypectomy, a colonoscopy and a polypectomy. We can just discuss that. Maybe I think more for registrars. Yeah. Maybe that is helpful. Do you have time, or are we? Do you all have any other questions? Okay. Sumutsa Modagan, shall we go to that? No, we are going, shall we do it another day?
Minutes,
Yeah, so basically, Pramod, can you run it? If I run, mic gets stuck from my end. So this is, sir, before until Sumutsa promote the video, now students, they have a lot of questions on how to prepare for a colonoscopy. Now, when you ask that question in the exam, people tell low fiber diet for 3 days, Dalcolax for 3 tablets for 3 days. That I think that is there in the lecture, their Kuppi teaching, I think. So how, if you are preparing a patient for colonoscopy, let's say you are going to do the colonoscopy next day morning, so how will you prepare?
Right. Yeah. Diet for 3 days and 3 for 2 days, and bowel preparation the day before if you're doing it in the morning, and from the morning if you are doing it in the evening. But if you are using 4 sachets of polyethylene glycol, right, this is not a drug which is going to get absorbed from the gut. So you can use it in renal failure patients. Single compromised functions is also not a contraindication to use glycol. If you are using polyethylene glycol, you don't have to 4 sachets of polyethylene glycol. You don't have to use. You don't have to be on a low fiber diet for 3 days and Dalcolax 3 tablets knocked off on another 2 days. You can do it on the very next day. if you are doing it in the evening, you can start it in the morning. But only thing is you shouldn't eat anything when you start polyethylene glycol. That is the most important thing. And fasting is not a must. Now, most of these procedures we do under conscious sedation. So there is no risk of aspiration. But some can theoretically argue that in case of a perforation, we have to give anesthesia, and for that patient should be kept fasting. But the incidence of perforation today is about 3 for 10,000, right? So if you are fasting patient, 9,997 patients unnecessarily for the benefit of 3 patients. And even if these patients were taking fluids, it is not a problem for the anesthetist because it take about 2-3 hours, even if when you perforate the colon, to take him to the theater. So it is only theoretical argument. So fasting is not a must and it is not necessary for these patients. So 4 sachets of clean prep and clear fluids, right? Colorless, not colorless. You can have sort of fluid like apple juice, where you can see through the glass. The best thing is to sort of advise the patient, when you pour it into the glass, you can see through it. Milk you can't have, right? When there is milk in the colon, you can't see through that. Right? So apple juice is okay, king coconut water is okay, plain tea is okay, right? Those things you can take with 4 sachets of clean prep at least 1 hour apart, because otherwise patients find it very difficult to cope up. But the timing, if it is you are more comfortable for the patient. And the procedure is ideally done at least about 4 hours after the last sachet of clean prep, because it will give, otherwise you will find colon full of fluid. So those are rough guidelines for preparing a patient for colonoscopy.
I have found now, let's say you are doing the colonoscopy in the morning at 8 o'clock and you all 4 packets of clean prep, and generally you finish it by 10 o'clock in the night. And when you try to do the colonoscopy in the morning, you find a lot of fluid in like have you found by giving other enema in the morning, does it make procedure?
The problem that is, if you give clean prep until 10 o'clock in the night, the problem is patient has to get up in the night to purge throughout the night. It is inhuman, I suppose. If you are giving it sort of, you should finish it by at least 6 o'clock, 7 o'clock in the evening the previous day, and they can continue clear fluids. And if it is very likely, as you said, sort of when you have such a long time the collected fluid in the colon, so putting a clean enema in the morning will purge it out.
Yeah. Students, are there any questions about power preparation? If you have questions, just ask now.
Excuse me, sir. Sir, I have read that about split dose and continuous dosing of these polyethylene glycols. Sir.
Yeah.
So can you please explain a bit regarding that?
We practice split dose. What you mean by split dose is you give, as I said, we use 4 packets of polyethylene glycol. What we do is we give 3 on the day before, and then after the night we give 1 in the morning of the procedure as a split dose. So 3 on the previous day and 1 on the day of the procedure. It has been shown that you get a better bowel preparation through split dose polyethylene glycol compared to continuous dose, right? Because overnight, probably what the patient accumulates colon washed away by the early morning. What we usually do is around 5 o'clock in the morning, we give the final dose. So by around 9 o'clock when we start the list, everything is passed out. And you get a better blood preparation and better visualization with split dose therapy. And yeah, basically how you there are different scoring systems and also lymphoma detection rate. How many polyps, in what percentage of people you detect polyps, is considered as quality indicators of colonoscopy and bowel preparation. So these have been better with split dose therapy.
I didn't know that.
Thank you, sir.
Yeah. Any other questions? Yeah. So, Supun, can you describe now if you see a lesion like this, how will you describe in a polyp? How will you you are writing the report. So if you see this, how will you type? What will you type?
Yes, sir.
What part do you think this is?
This is probably at the rectum. I can see the rectal folds.
Rectum is capacitors. This is unlikely to be in the rectum, I think.
Can this be the transverse colon?
Sir, the transverse colon, they have the angular cross-sectional areas, but here I can, that's not is it a fold, sir? That
I don't know. This is what you see.
Is right at
that is a transverse history.
So how will you describe this lesion?
My on the location.
Yeah. Okay. Yes, Supun. Yes. How will you describe this?
Okay, sir. First, I would decide on the location of the polyp which is placed. Now, in this case, as Moses said, that it is around upper rectal area, and whether it is anterior or posterior. Posterior depends on. There are techniques that to find that out.
It is extremely difficult to say whether it is anterior or posterior.
And if it is down, you can decide gross.
When the patient is supine,
yes,
then you can say. But how can you say by looking at this picture whether it is posterior?
Not this picture. I was referring to that mix.
But there is no water here to see.
Hello, sir.
Yeah. So now let's say you see this. Now, just will you write in the report?
Okay, sir. There's a. This is a polyp. This is a sessile polyp. So I can't see a peduncle. Sessile polyp. The size is around. The size I can't say, sir, without measuring. And it is a very what do you call indurated surface, and the indurated surface, and there are no mucosal bleeding on it. And I will also write what I like. It is soft to the colonoscopy probing, or whether it is hard to colonoscopy probing. I would state that also. And yes, sir, those are the basic details I would mention.
When you see,
sir,
do when you see this polyp?
So now the question is whether it's a malignant polyp or whether it's a benign polyp. So if it is a malignant polyp,
This is what you see. What do you think?
so I think this is probably a malignant polyp, depending on the outlook. This is very indurated, very uneven edges. So I think this is probably a malignant polyp. In this, I would. Hello, sir.
What will you do?
So if suspicious of malignant polyp, so I will not. modality, and then come back if if the imaging modality permits it.
You will not.
So that was what he said. What he said was he will take up.
He said he will not biopsy.
He will not biopsy.
Yeah.
What are you going to do then?
I will mark this area, and then I will do a imaging assessment on this patient, and I will come back.
What image?
So this is a so this is a rectal. So this is rectum area. So I would do a MRI pelvis in this case because I want to MRI pelvis or a endoanal ultrasound scan to decide whether it's infiltrating the dish T1, T2, or whether it is T3 or T4. If it is T1 or T2, then my management differs. Whether it is T1 lesion, my management differs. It is T2, T3, T4, management differs. Management is as for a rectal cancer. But if one,
Now, he said, can you I'm not clear. Now, but you said you are not going to take a biopsy, is it?
Yes, sir.
Is that you will? I'm not sure.
Sir, the thing is, my polyp excision decision takes whether it is indicated of a malignancy or whether we can take a polypectomy with low complication rates. In this case, it's more the polyp is more like a malignant polyp. So I don't want to risk it by just could always be a T2 or 3. So all the subsequent management will be problematic, sir. So in that case, I would just mark it first with Indian echo something.
Biopsy. Are you agreeing with that? Biopsy. He said he's not going to take a biopsy.
Agree or not? Yes and no. One thing I think when you see this thing, this looks suspicious polyp for me. Why it is suspicious? Because it is irregular and there is central dimpling here.
Yeah.
So it doesn't look very benign type of a polyp for me. And there is no peduncle and it is sessile, looks very sessile polyp. So I am not going to do a polypectomy here, but doing a biopsy is not going to do any harm. So and the most important, other important thing is you have to complete the colonoscopy because it is not completely obstructing the colon. You shouldn't sort of stop from here. He has sort of 5% chance that he can have similar lesion elsewhere or some other lesions of different stages elsewhere, more proximally.
Yes,
so complete the colonoscopy completely and take a biopsy from the lesion as well. And as you said, doing an imaging in the form of MRI and EUS to decide the infiltration of the base would be helpful here.
Because it's a flat polyp and we don't know whether it's T1 or T2. They say if you take a biopsy, you might cause scarring, which will prevent you from doing a mucosal, submucosal excision.
You are not taking a biopsy from the base.
Yeah, but don't they sort of say not to long flat polyps? It's better to avoid taking biopsies because you can cause scarring.
Yeah, but they say sort of you shouldn't scar the base, right? You shouldn't scar the base. If you scar the base, sort of elevation of the base will be problematic.
Yeah.
So you can take the biopsy from these overhanging polypoidal areas, but you shouldn't sort of try from the base.
Yeah, but the other thing is now in a polyp like this, let's say you take a biopsy, but that may not be a representative. I mean, this could be a carcinoma in situ or maybe early tumor. So the focus that you biopsy may not contain malignant tissue. So will that be a problem in decision making? Let's say you take a biopsy, it comes as high grade dysplasia, or still the patient might have malignant even if your biopsy is negative. Will that affect your management? Yeah. Is it a concern?
Sorry?
best is
Did you
to
get the
take
question? Yeah.
best is
Yeah.
to do the polyp mucosal resection or submucosal excision.
Yeah.
Rather than going for multiple biopsies. So that is why, as he said, you have to image because to decide whether it's amenable to submucosal excision. One lesion, you can submucosal excision. Otherwise, you'll have to just treat it as normal cancer and go ahead and do the anti-resection or whatever is indicated depending on the site. So it's always flat polyps. So recommended is take it as a whole. So to do that, you need you will have to exclude, you'll have to stage it first before you do a submucosal excision. And
so more biopsy, what is important is to see the T stage.
It is
or
important.
It is involved in the
yes. Because rather than without seeing the whole polyp, without seeing the whole lesion, the pathologist will not be able to tell you whether it's malignant or benign or what's going on. Yeah. So you need to take the whole polyp. To take the whole polyp, you need to make sure that it's what I would personally do in practice is look at it, and if it's not looking very malignant, if a sessile polyp, you can go for a complete excision of the polyp, flat polyp with a mucosal excision and send it for histology, isn't it?
Yeah, the macroscopic appearance of this polyp looks very nasty. You see sort of central dimpling, variegated appearance, and irregular edges, right? So this is more in favor of a malignant polyp, macroscopically.
Macroscopic. The question is T1 or T2?
Yes. The best investigation is EUS. MRI differentiation from T2 is difficult, but EUS also very operator dependent procedure.
Yes.
And can I comment about Supun's answering? Now, Supun's question, answers are, a lot of facts are there, but sometimes the answer is not focused. Now, the question was, how do you describe this lesion? The initial question, but then he went on telling a lot of things. But the exact answer for that question, if you are describing the most important lesion, I think, is to say that this is a malignant polyp because of the base and because of the irregular appearance, because it is sessile, and that if you are writing a report, that information should be there. Malignant looking polyp because of these reasons. That was not mentioned, but then you told a lot of things and then you kept on telling me a lot of unnecessary things as well. In answering, I think that you have to improve that. It should be a focused answer.
And the second important thing is how much the luminal involvement of it. Now, this is roughly about 1/3, not even 1/4. So that means sort of there is no impending obstruction. You have enough time to sort of work.
Now, if you are thinking of a submucosal resection, is that an important information? How much of circumference is involved by the society? Is that an important thing to decide on submucosal resection?
It is when you are doing a submucosal excision, the amount of the circumferential involvement doesn't matter because you can take any amount. But practically, it is difficult if it is more than 50%.
So it's a technical aspect. In rectal polyps, you can also go for adjuncts like putting in a transanal port and getting help with a laparoscopic equipment and so on. So to plan that, it's better to mention whether it's involving 50% of the circumference or 1/3 or 1/4 or whatever for you to decide the surgery. Because when it's a circumferential lesion, you're using gravity as the retractor here, so it might become difficult. You might turn the patient right around and elevate the polyp out of the submucosa.
So we discussed a few important things. Initially, we discussed how to prepare colonoscopy and how to identify different areas, the colon in the colonoscopy, and then if you are describing a lesion in the colonoscopy, what to mention, and then this is rectal upper rectal polyp, sessile polyp, and then we discuss the biopsy to biopsy or not, and then the most important thing in further management is to know that the stage of this, and then if it is not in the muscular artery, then we can think of submucosal resection. Is that correct?
Yeah.
Yes.
If this polyp is a transverse colon, is the management different?
Is there?
Yes, I'm here.
What do you think?
Transverse colon. What do you think?
Still, sir, we can try for endoscopic mucosal resection is possible. For a
Before
large
that, you have to stage disease, no?
yes. I mean, if it's a, yes, we can stage the disease. If it is a, I mean, said that if it's not a malignant once, we can go ahead with that management. If it is a transverse colon tumor, we can stage the disease, and if it is
How are you going to stage the disease?
sorry, sir.
How are you going to stage the disease?
We can do a contrast enhanced CT scan of the abdomen.
Now, what we want to see is whether it is a T1 tumor or T1, T2 differentiation. So, will CT be able to give that information?
CT, no, sir. CT is it is not. CT is not that good option to differentiate T1 and T2. Then the option would be to get a endoscopic count, but I'm not sure whether you will be whether it is
Endorectal sound and endorenal sound, okay. There are people who can do, but sort of most of the time colonic ultrasound, very few people in the world are capable of doing endocolonic ultrasound. And that different instrument, and very few instrument of is available in less than 10. Even if you doing a submucosal excision is not possible. So considering these two, what would do?
In that case, what we are left out is if it's a malignant polyp, we will have to go ahead with a right hemicolectomy. It's transverse colon, it should be an extended hemicolectomy, sir. We can go for a minimal invasive method like as a laparoscopic hemicolectomy would be better if we can, if it's
you don't do a CT scan at all.
We do, sir. I mean, after CT scan and after staging, if it is a malignant tumor, we do have to proceed with a right hemicolectomy in that case.
If it is in the transverse colon, isn't it important to biopsy now? Unlike the rectum, of course, you.
Yes, I mean, after biopsy, if the biopsy comes malignant, then we have to do the staging. So with a CT scan of the abdomen, and then we proceed since even if since we don't have facilities to differentiate between T1 and T2 tumor, as in the rectal tumors, then the next option would be to take out the malignant polyp. So we'll have to go ahead with the surgery.
Now, if it is biopsy says it is not malignant, do you leave it?
How do you know you have sampled the correct place?
So we'll have to take multiple biopsies, but still, because these are very malignant looking polyp, and there's a high chance of this can get converted into malignancy, because this may be having high areas of high grade dysplasia as well by the root. So I think leaving this polyp is not suitable.
Right. So whether biopsy done or not, it's not going to change your management, isn't it?
Yes, sir.
Now rectal polyp, if it is malignant, with the stage, biopsy has an impact before surgery, right? But
Yes.
in transverse colon, there is no impact, right? So you can't leave this polyp.
Can you clarify it a bit more, sir? I'm not very clear about it.
Now, when you take a biopsy here, whether it is malignant or not, you can't leave this polyp. And even if it is malignant, there is no neoadjuvant treatment for the transverse colon thing. Rectum, of course, there is. So here, whether you take a biopsy or not, is not going to change your management.
You have to take the entire polyp out and see. I would go for a full thickness section of the polyps.
Endoscopically?
No, it will be a combined procedure. Where I used to work, what we used to do was for until colonoscopy and locate the point of the polyp. We
can and inject before laparoscopy, no?
No, but
so you know.
Laparoscopically, we locate the place if it's a transverse colon and make through a small incision at the single port, we take out the transverse colon. And by looking endoscope, we used to mark it's called the taser. We used to mark the edge with pins, because you need a at least 2 centimeter margin around, and then resect along it and then close the and depending on the yes.
Right.
And,
but then you don't address lymph nodes.
Yeah, so depending on the histology, you have to go and do the proper surgery, because of otherwise saying whether we have missed a small part of the polyp which was malignant.
So there is a chance of doing another surgery.
Yes, because technically, if it's a large polyp, especially you can't expect anyone to do a submucosal excision.
Now promote the rectum. There is a well developed two muscle layers, inner circular and outer longitudinal layers. They are circumferentially developed thick layers. But in transverse colon, the outer longitudinal layer is a very thin and confined to 3 tinea. And inner circular layer is also relative to the rectum is very thin. So the chances of having a T1 lesion in the transverse colon of this is very remote. So I would rather do a conventional segmental resection with lymph nodes.
If it comes as a benign polyp is the only issue.
Yeah, looking at this sort of,
you have overtreated. I mean, this one won't be.
Sorry.
Yeah. Can't you remove the polyp in PK? Can't you remove the polyp piece and get as much as samples per, and then decide on that?
That is possible. The issue is chances of perforation is very high if sessile polyp, if you are trying to take the base in the transverse colon.
Snare it. Using a snare in the transverse colon is going to cause. So yeah, I mean, as a policy, where I worked in the UK, as a policy, they don't biopsy flat polyps. So what they do is either you do a submucosal after staging in the rectum, do a submucosal excision and see whether it's malignant or not, and take it from there. In the transverse colon, they had them because of this. What to do? Are we going to do a conventional colectomy, or You can't depend on the biopsies, so they developed this new technique, the combined endoscopic and laparoscopic. You take out the polyp, and if the polyp is clear, there are no malignancies going into the submucosa, you just leave it. If it's a T1 lesion even, then that's treatment. If it's a T2, then you go for conventional laparoscopic colectomy.
So what about endoscopic submucosal dissection? Because as I heard, sir, the advantage over EMR is that you can take the whole thing out separately without taking it piecemeal.
Transverse colon is a technical. It's not technically possible. It's very difficult with all your curves and all that.
Right.
Not like in the rectum.
There are people who do it in the cecum also, and close. Usually they get sort of perforations in the cecum. They use clips to sort of close this perforation. But there are, I think, less than 10 people in the world who sort of have ability to do that. So they are not usual procedures.
Okay, sir. Okay, sir. Thank you, sir.
Can you run the video? Yeah. So now we'll ask Somundu sir what this step is. Now they have decided to do a EMR. What are we doing here?
It seems they are injecting the base with methylene blue and probably either 10% glucose solution or gelatinous solution. Gelatin solution is better because it lasts longer for us to do a submucosal resection.
Why methylene blue is injected?
That gives a very clear beam, but it should not be very concentrated methylene blue. When you are, and some people add little bit of adrenaline, 1 in 100,000 also, and others don't.
You can see it's nicely elevated from the submucosa.
So that itself suggests it is not a T2 lesion definitely. It is confined to the mucosa. If it is going through the mucosa, right, the center of the lesion will not get elevated.
This is why we don't like to take biopsies from the base or the middle. The scarring will not allow this elevation.
So it is injected in submucosa, right?
Yes. The finding this place is also important. You use a lot of small needle, 23 is preferably, because if you use a larger needle, the fluid will leaks and this will get flattened again. So you use this needle and penetrate. Sometimes you go into the muscle, then you feel a lot of resistance and sort of mucosa will not get elevated. So you first you try to elevate little away from the lesion. So when you get that plane, now the mucosa is separated from the underlying tissues, then use that plane, you can completely insert the needle and elevate.
They are doing a snare on this. They are not going to.
This is not appropriate once you elevate it, because again you have neck between the humor and the this thing. So what you should do is sort of submucosal resection, where you use scalp diathermy and dissect away from the polyp in the submucosal plane. Once you cut right round that, you can use a snare.
And if you see a sort of a very benign looking flat polyp in the rectums, will you at the same time when you do the colonoscopy, will you do a resection, or will you wait for the imaging even there?
If I see a very benign looking flat polyp, right, even I don't sort of think here the MRI will be able to differentiate T1 and T2 very accurately. So if I feel that during endoscopy it is very benign, I'll do the submucosal resection at the same time.
I see they left apart there as well.
Yeah, that is because they snared it.
This polyp could have been nicely resected on the submucosal way. Now this is piecemeal resection. It would be difficult for the pathologist also to comment on the margins. And
So what are you going to do for the defect?
So I'm not sure, sir. I'm not sure. I'm not sure, sir. Sorry.
Are you going to apply any clips?
So if the base is not bleeding, I would just leave it because it's just a submucosal endoscopy mucosal resection. So it's unlikely to have like a bad bleed out there. So I would just leave it. If there is no bleed.
Right. Yes. You don't have to do anything unless you create a perforation. Do a perforation. How do you know that you have perforation? So how do you know that you have not perforated during this procedure?
One thing is, again, if it is we are on the mucosa, there is hardly any bleeding. So if you have perforated, there would be bleeding. That's number one. And if I then, sir, endoscopically, if it is a huge perforation, we would be able to see the peritoneal structures as well. And clinically, the patient will get
surrounding the rectum. We were cutting today.
So if it is a rectum area, so I would probably see around about like seminal vesicles anteriorly.
They are very theoretical.
If you see the seminal vesicles, there is no question.
If there is such a big perforation, you will not be able to maintain distension with air in the colon, right? That's the first thing you lose. However much you insufflate will be leaked. Patient is stressed. That's abdominal distension and very painful when the peritoneum is stretched without being anesthetized. Other thing, before that you see fat. Now you won't get you don't see other structures usually, but you see sort of fat. Right? If you see yellow things, right, that means you have gone through the entire bowel bone, right, in the rectum. Because mesorectum is right now. If you see yellow fat, that's the first thing sort of you have to suspect.
Yes, sir. Yes, sir.
What can you do if you create do? What would you do?
You have to take to theater, laparotomy, or
if it is a perforation, I think we have to do a surgery. But before that, prevent any further injury. Definitely abandon the procedure. And the other thing is, if there are any methods of clipping this defect, I would just clip it just enough to prevent further progression of the disease. Is it right, sir?
If you are using, what type of clip you use? You have seen sort of people using endoscopic clips. Now you see the endoscopic clip which we use after to close mucosa, following probably poem and all that, the commonly used clip are to close mucosal defects. They don't go through muscles. They are not long enough to go through the muscles. Right? Even if you close only the mucosa without approximating muscle, it is not going to last long. So you have to sort of use special type of a clip if you are going to close using clips. not sort of just mucosal clips.
These
Right? These are mucosal clips. Right? So he's going to do. Does this? You don't need to sort of do this thing. Right? And if there is a perforation, this clip is not going to work.
And perforation in a place like this not require surgery, in my opinion, because this is prepared bowel, right? And you know, it is beyond the peritoneal reflection. So in this sort of one, you can actually manage them either with a clip or transanally you can repair it. Put a suture, start the patient on antibiotics. You don't need to go take to the theater and do ileostomies or anything like that.
And if you take him to the theater, it is a big surgery. It is not sort of open option you see. Right?
Mobilize the rectum and
yeah. So these are not the clips which you have to use. You have to use sort of a bear hug clips which approximate the muscle as well. Right? This is not necessary. Probably they want to, I don't know whether they want to tag this area. Ideal way of tagging this area is using black dye.
It will fall off in few minutes.
What are they going to do? They are going to occlude that.
Yeah. Are there any other questions from students or others? Yes. Specimen is it important? Are there any important things? Do you have to pin it around this thing, or can you just send in like a normal specimen? Are there anything special?
You have to pin it in a piece of cardboard and orient it, especially because the pathologist will then let you know which margin is involved or which margin is clear, especially the deep margin if it's malignancy. Currently people believe it's just 0.1 millimeter clearance is enough for submucosal resection. If you have R0 basically. You don't need millimeters and millimeters. The 0.1 is the current practice. There's 1/10 of a millimeter. If it's microscopically clear, it's enough. So to do that, you need to properly orient the specimen. We usually do use a piece of cardboard and pin it, and also mark where the superficial, right up and bottom, orient the specimen as it was resected from the rectum. They are using more tips than
This is done by a medical gastroenterologist. And he is using clips without any mercy.
Patient will not be able to pick it.
Enjoying it.
Even a full thickness defect does not need this closure in the top.
Okay, are there any questions from the others?
Sir, why does sessile serrated adenomas have a higher malignant risk, sir?
Serrated or sessile, those are two words. Serrated adenoma is a different component.
Sessile one, sir.
Yeah. Sessile one is where you don't have a peduncle, right? So those are two terms. What you're asking is why there is a higher risk of malignancy, isn't it?
Yes, in sessile adenomas.
Yeah, it's being observed that sessile adenomas they are usually they present as there is a higher incidence because of the molecular arrangement of the structure. You know, like when you get the polyp, what you get the polyp to carcinoma sequence, right? So you have the pedunculated polyps. They remain as benign lesions for a longer time and then undergo malignant changes, right? But in sessile polyps, It's the same, the mechanism, the molecular structures, that the hits that occur, the FAP gene, the P53, those DCC, those genes get mutated, but they've observed that in sessile polyps, there is a more chance that they have gone into the malignant transformation earlier, right? And also, when you get a malignant transformation in a pedunculated polyp, unless it has gone into the stalk, it does not truly reflect a malignancy. You can have epithelial malignancy, but it has not gone into the stalk, right? In a sessile polyp, you don't have a stalk. So whatever there is, the epithelial malignancy that takes place, it will quickly get involved with the full-blown malignancy, right? A polyp cancer in a pedunculated polyp, just a snare polypectomy is enough as long as it has not gone deep into the stalk. But in a sessile polyp, you don't have that stalk. So most of the time, even the epithelial malignancy has gone beyond T1 and it has become a full-blown malignancy, right? So it's a molecular, the molecular events that take place in giving rise to a sessile polyp are more towards malignant transformation rather than a pedunculated polyp, because you and all of us can have pedunculated polyps with age, and then they take a long time for molecular hits to go on and transform into a malignancy.
Okay,
Serrated adenomas, on the other hand, are found more on the right side, and small ones. Serrated is given to the histological appearance of the polyp, right? They are found mainly in relation to cancer families, familial non-polyposis colorectal cancers, and familial, those are the more on the right side, and we are very small ones. Even the small ones, usually we say if the polyp is less than 1 centimeter, the malignant risk is low. But in serrated adenomas, even the small ones have a greater malignant potential. And also, to detect serrated adenomas, you need to keep on surveilling those patients more frequently rather than finding normal adenomas. Right? Serrated is a histological appearance. They are serrated like a kiyatak dati wage. They have a serrated edge. They are a different entity because they have they have a higher number of microsatellite instability, single nucleotide defects, mutations that occur in most of these genes. Right? So MSI, microsatellite instability, is higher in serrated adenomas. So those people have a higher chance of getting cancers, right, especially on the right side.
Thank you, sir.
Yeah, tomorrow I think we thought of discussing about the fluid balance, perioperative, post-operative, and probably pre-operative, and also shock, hypovolemic shock, and other types of shocks. Can you all arrange one of the second year students or maybe third year to describe the fluid and electrolyte distribution in the body fluids,
and mechanism of formation of body fluids, Starling laws.
Yeah, okay. Starling forces and the distribution of body fluids, physiology. Can you all arrange someone?
Okay, sir.
Right. Okay. I think that's enough for today. No, are there any? If there are no other questions, we'll stop for today. Yeah. Okay then.
Thank you, sir.
Thank you.